Excellent. So the next thing that I want to do is I want to just cover, since we'll be talking about cardiac arrest this afternoon with ventricular dysrhythmias, I just want to cover the American Heart Association guidelines or algorithms as they pertain to cardiac arrest. Of course, we talked about the bradycardias and the tachycardias last week. Today, we'll talk about cardiac arrest. And then, of course, tomorrow, we'll talk about the acute coronary syndromes or ACSs. These are sometimes referred to as OMI. That is a new term that is becoming a little more popular. It's called OMI, or occlusive myocardial infarction. And that's just it's essentially, it is a synonym for an acute coronary syndrome, where you have an acute obstruction that causes rapid, sudden onset ischemia, injury, and even potentially necrosis. And that is typically due to a blood clot that forms within a coronary artery and blocks perfusion downstream. And that clot is generally the result of a plaque. So you get plaque formation on the inner surface, inner lumen of the arteries, what we call the intimal. And just like many different structures in the body, vessels have three different layers or components to them. They've got an outer layer, an inner layer, a media, and then or a middle layer, media, and then the innermost layer, the intima. And when that plaque ruptures, that exposes collagen. And if you remember back to pathophysiology, the exposure of collagen activates the clotting cascade. It activates the intrinsic pathway specifically, which then goes into the common pathway and eventually results in the formation of a fibrin plug. And so that's the basic pathophysiology of an acute coronary syndrome. There are more chronic problems where the atherosclerosis, or the plaque that has formed, and the arteriosclerosis, the hardening, quote unquote, of the artery, causes a chronic decrease in perfusion. And when the heart is put under stress, there is an oxygenation mismatch, right? The workload increases, but the oxygen or the perfusion doesn't increase, and that causes ischemia. Of course, we refer to that as angina pectoris or pectoralis, which is a more chronic condition as opposed to an acute obstruction of a coronary vessel due to rupture of an unstable plaque, typically. But we'll talk about that in more detail tomorrow. All right, so let me go ahead and share the cardiac arrest algorithm with you all, just to make sure everybody's on the same page here. All right, so here is the current adult cardiac arrest algorithm. Just like all the other algorithms, start at the top and work your way down, follow it. So the patient is in cardiac arrest. What do? We start CPR, minister oxygen, and attach a monitor defibrillator to that patient. And then we differentiate cardiac arrest by two major paradigms. And that, of course, is this first object here. Remember, these hexagonal structures are critical questions that we need to ask. So we need to ask ourselves first, is this a shockable rhythm? And that is to say that, is this a rhythm that we can defibrillate? And we talked about, and of course you learned how to manually defibrillate last week. And remember, there were only two shockable rhythms: ventricular fibrillation and pulseless ventricular tachycardia. That's not entirely true, because unstable torsade de pointe may present with a pulse, but we tend to defibrillate that immediately if it's unstable. But that more or less falls under the umbrella of pulseless ventricular tachycardia, since torsades is a form of ventricular tachycardia. It's a special form known as a polymorphic ventricular tachycardia. So that's if it is shockable. If it is not shockable, there are two rhythms that are considered not shockable: asystole and pulseless electrical activity. And we talked a little bit about what PEA is, pulseless electrical activity, last week, and we said that it is any organized rhythm. Now, ventricular fibrillation and pulseless VTAC are not considered organized rhythms, so they do not fall under the umbrella of PEA. So PEA is anything other than that that has some organization to it, that looks like it should produce a pulse but doesn't. We call it PEA and asystole, and these are non-shockable. So the treatment varies a little bit, and primarily you do not defibrillate asystole in PEA like you do ventricular fibrillation and pulseless ventricular tachycardia. Everybody gets CPR, and everybody in cardiac arrest will receive epinephrine if they stay in cardiac arrest. The primary treatment for a shockable rhythm, in addition to CPR, is defibrillation. So we defibrillate them as soon as possible, minimizing interruption to compressions, right? To include compressing while you are charging to defibrillate. All right, so start CPR, shockable rhythm, shock them, and then do CPR for a full 2 minutes. And while you're doing your 2 minutes of CPR, after you defibrillate them, you want to get vascular access. That could either be IV or IO. And then after 2 minutes, you ask yourself, is this a shockable rhythm? If yes, shock them again. Do another 2 minutes of CPR. And if the patient is in refractory pulseless VTAC or fibrillation, refractory means it is not responding to treatment, the primary treatment, CPR and defibrillation, then you can administer epinephrine, right? And they recommend 1 milligram of epinephrine every 3 to 5 minutes of the 1 milligram in 10 milliliter concentration, sometimes referred to as 1 to 10,000, not 1 to 1,000. 1 to 1,000 epinephrine should never, and I repeat, never be given IV. All right. Now, asystole and PEA is treated a little differently. Instead of defibrillating it, you continue CPR and you administer epinephrine as soon as possible. And then you continue administering epinephrine every 3 to 5 minutes and consider techniques, more invasive airway management techniques, if they need to be employed. And then every 2 minutes, you are rechecking to see if you have a shockable rhythm or not. All right. And of course, you are also checking a pulse every 2 minutes to see if there is a pulse. And if you do get a pulse back, we call that ROSC, or return of spontaneous circulation. And at that point, you stop with the cardiac arrest algorithm because the patient is no longer in cardiac arrest. And then you move to another algorithm. And of course, that algorithm is referred to as ROSC, return of spontaneous circulation algorithm. We're not going to talk about that today. We will talk about that in cardiology. In fact, you all will be taking advanced cardiac life support as part of the requirements to complete cardiovascular emergencies, but that will be later on in April. Actually, that'll be the last class you take of the semester. Now, in a shockable rhythm, if the patient is refractory to defibrillation and refractory to epinephrine, you can also administer an antidysrhythmic. And the two antidysrhythmics that they tend to recommend are amiodarone or lidocaine. Now, this is important. It is not amiodarone and lidocaine. It is amiodarone or lidocaine. You choose one or the other. You don't give both. All right. And which one to go with depends on the situation, right? If this is a patient that has a prolonged QT interval, and they're on multiple drugs that prolongs their QT interval, you might want to steer clear of something like amiodarone because it prolongs the QT interval, and maybe consider lidocaine. But when we look at the evidence as far as people surviving discharge or surviving to discharge or actually getting to go home with some degree of intact neurological status, there doesn't appear to be a substantial difference between amiodarone or lidocaine. Remember, you're dosing for amiodarone, you're dosing for lidocaine. If you forget, these little boxes here on the right-hand side of the algorithms tell you the dose, right? And they give you additional context if you need it. So please use those. You shouldn't be guessing on dosing for these different paradigms because it is very easy to reference on these algorithms. All right, and that really is it. And always remember the potential reversible causes. And these are causes that you need to think about in every person who presents with a dysrhythmia. I mentioned them last week, and I just want to talk about them again today. Somebody presents with a cardiac dysrhythmia, right? You need to work through these and ask yourself, could this patient be experiencing these? So these are what we call the H's and T's, all right? So hypovolemia, right? If someone has been, right, Mozambiqued, right? They took 2 rounds to the chest and 1 to the head, and they've lost their circulating volume and their impulsus electrical activity because there's no blood volume for the heart to pump, right? That's something that we need to correct, right? We need to get fluids and blood products in them potentially, right? Are they hypovolemic? Is it hypovolemic shock that is maybe causing this dysrhythmia? Are they hypoxic? Hypoxia is a substantial driver for dysrhythmias. Remember, the heart, in addition to a couple of other organs like the brain and the kidneys, does not tolerate ischemia very well. And so when the heart becomes ischemic, in adults at least, the heart rate will increase. And then as those tissues become more ischemic due to that hypoxia, then you can get what's called ectopy, right? You can get ectopic foci. Areas of the heart become kind of angry and begin depolarizing on their own because of that ischemia, and they can lead to the onset and further development or exacerbation of dysrhythmias. Hydrogen ion, think of acidosis, right? If somebody become acidotic, severe respiratory, or in many cases, metabolic acidosis. Potassium, remember back to pathophysiology, we said sodium imbalances tend to impact the brain. Potassium imbalances tend to impact the heart. Why? Because potassium is incredibly important when it comes to repolarization. So potassium imbalances tend to impact repolarization. So hypo and hyperkalemia. Hypothermia, low body temperature, right? And there are actually some characteristic ECG changes that can occur. They're called Osborne or J waves, and we'll be talking about those a little later on in this course. Tomorrow afternoon, when we talk about the various things that can mimic a STEMI, something called a STEMI or an ST elevation myocardial infarction. There are many things that can mimic a STEMI, kind of look like a STEMI, but are not. And severe hypothermia is one of them. Tension pneumothorax, right? Cardiac tamponade, toxins, right? Toxicology, lots of different things can impact the heart. Thrombosis, that's a blood clot, either in the lungs or in the heart, coronary thrombosis. So those are the major causes. And some of these are potentially reversible, right? If somebody is severely hyperkalemic, for example, there are things we can do that might substantially or drastically improve that patient's situation, right? So that's why you need to think about the differentials, the differential diagnoses, and these are the primary differential diagnoses you want to be thinking about. Could any of these be going on? And is there anything I could do to correct these potentially? All right, so that is the general way that we approach cardiac arrest in the adult patient. Pediatric patients are a little different, right? Pediatric patients, when they become hypoxic, they tend to become bradycardic very quickly. Whereas adults tend to become tachycardic, and they tend to have ectopy. They tend to have premature complexes, PACs, PVCs, PJCs, things like that. Whereas kids tend to become bradycardic in the setting of hypoxia. Adults will initially become tachycardic, and then in severe cases, when their heart and their brain is severely ischemic, they will too develop bradycardia. So bradycardic and tachycardic dysrhythmias are commonly associated with hypoxia, and there are various things that can result in hypoxia that you want to be thinking about. Okay, so any questions about the general way in which we approach cardiac arrest? It's not too different from what you all learned as advanced EMTs, hopefully. Should be fairly straightforward. Okay, I think I'm caught up in chat. Okay, excellent. Well, with that in mind, let's move forward and talk about some additional dysrhythmias. So what I'm going to talk about now, or I'm going to talk about a group of disorders collectively known as the heart blocks. That's more of a vernacular term, but more appropriately, they are known as the AV blocks, or atrial ventricular blocks. So this is essentially where you have a situation where you have either a delay or sometimes a complete block of conduction from the top part of the heart down to the bottom part of the heart. That is to say that the SA node, impulses from the SA node cannot get down to the lower parts of the heart. And this is often due to ischemia or damage, and sometimes this can be toxicologically induced damage, or it can be due to the vagus nerve and increased vagal response that decreases the conduction through the intranodal pathways, or sometimes the AV junction itself can fail, and so you cannot get in, the wave of depolarization gets stalled out at the AV junction, right? So there are various causes for these. And what we're going to do is we're going to talk about these so-called heart blocks or so-called AV blocks. So let me go ahead into screen share here. There we go. Looks like we've got it going. All right. Let's talk about these. So these are the main topics I'm going to talk about this morning. I'm going to talk about the AV blocks. I'm going to talk about the first degree AV block, the second degree AV block, and the secondary AV block is falls under two major categories. There's the type 1 and the type 2. The type 1 second degree block is sometimes referred to as a Mobitz 1 or a Winkie-Bach heart block. So type 2, a second degree AV block type 1, it can be referred to with many names. It can be referred to as a Mobitz 1 or a Winkie-Bach or a second degree type 1 or a second degree heart block type 1 or second degree AV block type 1. Then there is the second degree AV block type 2, which is sometimes referred to as a Mobitz 2. All right, so those are synonyms. And then there is something called a third degree AV block, often referred to as a complete heart block or CHB. All right, so third degree AV block is also known as a complete heart block. We will also talk about paced rhythms this morning as well. And I'll talk about a little bit about the codes, what it looks like, and some of the problems associated with a pacemaker failure. But before that, let's talk about these AV blocks. So let's talk about the first one, also referred to as a first degree AV block. Please enlarge that. So a first degree AV block is actually not considered a true block. So it is not a blockage of conduction, but rather it is a delay in conduction. And the characteristic finding that we see with the first degree AV block is a P to R interval that is greater than 0.2 seconds. All right, that is 5 small boxes or 1 large box. So if we look at this rhythm strip here, you can see, let me do this in blue. I have a P wave that starts right at the beginning of this box here. And so here is 1 large box, or 5. So this is 0.2 seconds. And then I have another box and a half, right? So this is clearly greater than 0.2 seconds. So because a first degree AV block is not considered a true block, we would always identify the underlying rhythm. So this is kind of like an add-on, just like a PAC or a PJC or something called a PVC, which we'll talk about this afternoon, right? You would not, if you saw a sinus rhythm that had PACs in it, you would not say, oh, this is a PAC dysrhythmia, right? You would say, oh, this is a sinus rhythm with PACs or a sinus rhythm with PJCs. Think of a first degree AV block in the same way. So the underlying rhythm is still sinus, right? And what makes it a sinus? Well, what's the rate? 1, 2, 3, 4, 5, 6, 7. So the rate here is 70. What's the rhythm? The rhythm is regular. Is there a P wave for every QRS and a QRS for every P? Yeah, right? P's is a P for every QRS, QRS for every P, right? The QRS duration, the QRSs are narrow there, they're less than 0.12 seconds. And the only abnormality is this prolonged P to R interval. So the sinus node is in control. It's just that it is taking a little longer than usual for that wave of depolarization to get down into the ventricles. And so that's why we would say that the underlying rhythm is still sinus here, because the sinus node is clearly in control, but there's a first degree AV block that is prolonging the conduction. Now, this may be a benign issue. So a first degree AV block may be very benign, especially if the heart rate is adequate. If there's an adequate heart rate and the patient's cardiac output's okay, it may be benign, or it might be indicative of other problems such as H's and T's, medications, ischemia, increased vagal tone, right? Someone had vasovagal syncope, for example, right, where they bear down, increased their vagal tone, that decreased the heart rate, that delayed conduction through the atria, right? Somebody has constipation and they're on the toilet, for example, and bearing down. Things like that can do it. So we essentially treat a first degree AV block if it is resulting in decreased heart rate with symptoms. So essentially, we would treat a first degree AV block as a symptomatic bradycardia. And we talked about the symptomatic bradycardia algorithm last week. Otherwise, you just monitor, right? Watch and monitor. And I suppose this is a good point to bring up since we will start doing this in lab, and that is the static cardiology. And remember, I talked about static cardiology, and I said that the task condition standard for the static cardiology test out or exercise is you are given 4 scenarios. You have to read a paragraph, and then you'll have either a rhythm strip or a 12 lead with each scenario. And then you'll have a total of 6 minutes to identify the rhythm, and then to verbalize the treatment for each of those rhythms. And so this is a good time to talk about treatment. And so in that setting, what kind of treatment does everybody get? Well, let me identify the treatment that pretty much everybody with any sort of dysrhythmia is going to get. All right. So everybody's going to get vascular access. So they're going to get an IV. Everybody's going to get oxygen if they need it. So O2 PRN, IV oxygen as needed. Monitor them, right? They're going to need close monitoring. If it has not been done, it should be done. They will need a 12 lead. They will need a 12 lead ECG. They will also need transport. And they will need reassessment. So regardless of the rhythm, everybody gets this treatment here, right? Everybody's going to get an IV. Everyone's going to get oxygen if they need it. Everyone's going to get monitored. Everyone's going to get a 12 lead. Everyone's going to get transported, and everyone's going to get reassessed. And then depending on what else is going on, there may be special things. Maybe you'll need to give atropine or pace or do CPR or defibrillate or what have you. But you start off with that treatment. And so these should be the first things that come out of your mouth when you verbalize the treatment, right? Because this applies to everybody. Doesn't matter if they're in cardiac arrest or not, right? They're going to get vascular access. They're going to get oxygen as needed. They're going to get monitored closely. They're going to get a 12 lead. They're going to get transported, and they're going to get reassessment. All right. So that's just kind of a pro tip for that. Okay. So let's move on to the actual AV blocks. And the first of the actual is something called a second degree type 1. Remember, the second degree type 1 is also known as a Mobitz 1, or sometimes it is referred to as a Winky block. All right. So the classic presentation of a second degree AV block is a P to R interval that progressively increases. So you have a progressively increasing P to R interval until a QRS is dropped. And that is to say that you have a P wave without a QRS complex. So you have more P's than QRSs. So let's look at an example of a second degree type 1, aka Mobitz 1, aka Winky block. So if we look at this here, look at this PQRST complex here. And I'm going to point out the P wave. And then we're going to look at the one next to it, the second one here. What do you notice about the P to R interval here? What has happened there?
Increased.
It is increased. Let's look at the third complex. The P to R interval has gotten even longer. Yep, it is prolonged. Yes, sir. And then we have a P wave here. We have a blank space here. And then we have another P wave and a QRS here. So I have a dropped QRS complex. So the P to R interval started off decent here. It got long, it got longer, and then the QRS dropped, and then the whole thing reset and it started all over again. So you see that this complex right here after the dropped QRS looks like this one. And then this second one, it gets longer, and this second one looks like this second one. And then this third one looks like this third one here. So you have this repeating pattern of a prolonged P to R interval followed by a dropped QRS complex, and then the whole thing resets, and the PDR interval gets progressively longer until you have a dropped QRS complex, and then it resets, and so on and so forth. And that is the classic thing that we see with the second degree type 1, Mobitz 1 Winky-Bach. All right. So this indicates that there is an actual conduction block through the AV node. All right. It's not complete, but there is an actual block occurring. And this may be due to ischemia, infarct, drug effects, or potentially vagal tone. And another pro tip is the more advanced the AV block, the more advanced, or what we call a high grade AV block or more advanced AV block is less likely due to vagal tone. So a first degree AV block is more likely to be due to increased vagal tone than, say, a third degree or complete heart block. And so what you can anticipate here is the higher grade the AV block, the less likely it is to respond to atropine. So atropine is more likely to be ineffective when you have a high grade AV block. And so this has led to some people that will say, I don't even give atropine if there is a high grade AV block. Now, there is some logic to that because the atropine may not work. However, for our purposes, we are going to follow the American Heart Association algorithm. And if somebody has an AV block, and the typical problem associated with these higher grade AV blocks is going to be a decreased heart rate, because you are losing QRS complexes, right? You're losing ventricular contraction potentially. And so that is going to result in a low heart rate, which is going to result in a symptomatic bradycardia. And we treat that with the bradycardia algorithm. The bradycardia algorithm doesn't really care what the cause of the symptomatic bradycardia is. It doesn't matter if it is a sinus bradycardia, a junctional escape rhythm, a high-grade AV block. It just matters that the rate is low and it is causing some symptoms. And so the treatment is standardized, and it starts off with atropine. But with that in mind, the atropine is less likely to be effective with these higher grade AV blocks, because the higher grade AV blocks are due to an actual blockage, typically damage to the AV node, and atropine doesn't reverse AV nodal damage or AV junction damage, or doesn't reverse damage to the internodal pathways. It just blocks the parasympathetic nervous system, right? And so for atropine to really work, you actually have to have a functioning conduction system. And if the bradycardia is due to irreversible damage in the cardiac conduction system, then atropine is less likely to be effective, right? And we may or may not know that, right? But when you give atropine and you don't get that response like we talked about last week, then that tells you, okay, this is a situation where there may be physical damage to the conduction system. And so this is a patient that may need more definitive therapy, i.e., they're going to need a pacemaker or something on those lines. All right. So that is a second degree AV block type 1, Mobitz 1 or Winky-Bach. So what I want to do now is I want to talk about the high grade second degree AV block. And that is called a second degree AV block type 2. This can be confusing And this can easily be confused with other heart blocks, specifically third-degree AV blocks or complete heart blocks. So let's just talk about what a second-degree AV block type 2 is, also known as a Mobitz 2. So in a second-degree AV block, you are going to have dropped QRS complexes without a change to the P to R interval. All right. So the P to R interval on the complexes that get through does not change. So what you're going to have is you're going to have a P to R interval that is constant on your QRS complexes, and then you're just going to have P waves without QRS complexes, right? So you're going to have dropped QRS complexes like a type 1 or a Mobitz 1, but the P to R interval won't change. And to make it even more complicated, there may or may not be a pattern to the drop QRS complexes. And so what I'm going to do is I'm going to give you a few examples here. So let's look at this first example. So you can see I've got a P, QRS, and T, and you see the P to R interval is the same here as it is here as it is here. It doesn't change, right? And then can you all see that I've got a P wave here without a QRS complex? So I have a dropped QRS complex, I have a P wave here, and I have a dropped QRS complex. But the P to R interval on all the other QRS complexes is the same. That's what makes this a second degree type 2. All right. You're just having dropped QRS complexes. Now, this is a situation where there may not be a specific pattern. There might be if we printed off a longer rhythm strip, but we can't really tell if there's a pattern here. However, there can be a pattern to a second degree AV block type 2. And so let me give you some examples of patterns that can emerge. All right. So this second strip is another example of a second degree AV block type 2. So you can see that the P to R interval, let me do that in blue. The P to R interval here is the same as a P to R interval here, is the same as a P to R interval here, is the same as a P to R interval here. But you see that I've got a P wave here, and a P wave here, and a P wave here. So what I have is I have 1, 2, 3 P waves for every QRS complex. I've got 1, 2, 3 P waves and a QRS complex. 1, 2, 3 P waves and a QRS complex. So I have a 3-to-1 pattern. 3 P waves for every 1 QRS. It's still a Mobitz 2 because the P to R interval on the conducted P waves is the same. But in this case, I actually have a pattern. And then the third example is what is another pattern. So if we look at this one, here's the P wave and the P to R interval, P wave, the P to R interval. And you can see that the P to R interval is consistent. But if you look, I've got a P wave without a QRS here and a P wave without a QRS. So I have 1, 2 P waves and then a QRS, 1, 2 Q waves and a QRS. So I have a second degree AV block, but instead of a 3-to-1 pattern, I have a 2-to-1 pattern, 2 P waves for every 1 QRS complex. All right. So those are some examples of the Mobitz 2. So the Mobitz 2 or second degree AV block type 2 tends to be much more symptomatic because the heart rates tend to be lower. the causes are the same as a type 1, but a type 2 often requires a permanent pacemaker to manage. This is typically the result of permanent and irreversible damage to the conduction system. And again, this is considered a high-grade AV block, and so it may not respond to atropine. You may not have a great response to atropine, and that's okay, because you know what to do if the heart rate doesn't increase when you give atropine. All right, so before we move on, are there any questions? Any questions?
Do the P waves count for heart rate, or is it just going to be with the whatever comes with the QRS?
Now, ask that again. I'm sorry.
The heart rate, is that going to be coincidental with QRS, or just it includes the P waves without the QRS?
So yeah, so the cardiac output is due to the QRSs, right? If the QRS results in contraction, your cardiac output is due to the ventricular contraction, right? So that's where most of your cardiac output's coming from. These P waves without a QRS are not going to result in cardiac output. Blood's not pumping out of the heart there. Did that answer the question okay? Or
yes, sir. Good, thank you.
Okay, yeah. And that's really the big problem with these high-grade AV blocks is the ventricular rate gets so low that the cardiac output, right? So remember, cardiac output equals heart rate times stroke volume. And so with these high-grade AV blocks, the heart rate gets so low, the ventricular contraction rate gets so low that the cardiac output gets too low. And then the patient isn't perfusing their brain and vital organs and so on. All right. Well, let's see here. Oh, yeah, we still have a little bit of time. So I'm going to move on and talk about complete heart blocks, or what are referred to as third-degree AV blocks. So a third-degree AV block is very tricky, and it can look a lot like a second-degree type 2. And second-degree type 2 can look an awful lot like a third degree. So a third-degree AV block is a complete block at the AV node or junction. So that means that the SA node cannot get information through the AV junction, right? So the AV junction is blocked. And so what happens is the SA node fires on its own. It's doing its own thing, and either the AV junction or sometimes the ventricles will begin firing and doing their own thing. And so what's going to happen is the P waves are not going to be related to the QRSs. And so the SA node fires at its intrinsic rate, and then the AV junction fires at its intrinsic rate. And if the AV junction completely fails, then sometimes even the ventricles will fire, and that'll be a ventricular escape rhythm or a junctional rhythm. So what you get is a total separation of the atria from the ventricles, electrically speaking. And what will happen is the P waves will, quote unquote, march out. So the P waves will be doing their own thing, and the QRSs will be doing their own thing. They will march out. So what you will get is you will get P waves all over the place, and you will get P waves on the QRSs or P waves on the T waves. And those are some of the classic things that you look at to tell you that you're dealing with a complete heart block. So let me go through some examples before we take our first break. All right. So let's take a look at this first one here. All right. So let's take a look for P waves. Everybody see there's a P wave there, and see this T wave down here and this T wave here, and this T wave here, and you see this little bump that's out of place here, right? Well, that little bump is actually a P wave that's buried, and then there's a P wave here and a P wave here. Oh, get back there. There's a P wave here. 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 All right. So you got P waves all over the place. And now you could fool yourself into thinking maybe this one here, right, is associated with this QRS. And then you could fool yourself into think, well, maybe this is some sort of second degree AV block. But if you just look at it, the P waves are just doing their own thing, right? And you've got a P wave here and a T wave. Then you have a P wave here right after the T wave, right? So these P's are clearly just kind of doing their own thing. And then the QRSs are very slow and wide in doing their own thing. All right. So you can actually see that the P's and the QRS complexes are unrelated. And then you have this very slow, wide QRS rhythm. And this is actually something called a ventricular escape rhythm, right? And so the ventricles are actually doing their own thing. So the atria is doing their own thing. And then the ventricles are doing their own thing. And they're not at all related. They're not talking at all. They're not able to communicate. All right. Now, if we look at the second one here, this is another kind of tricky one. So you can really fool yourself into thinking that this is second degree type 2, because look, here's a P wave, and here's a QRS complex, and here's a P wave, and here's a QRS complex, and here's a P wave, and here's a QRS complex. Oh, snap. Look at this. This is a 3-to-1, right? This is a Mobitz 2 3-to-1 conduction. But if you look a little more carefully, look at the T wave here. See how smooth that is? And look at this little bump here on that T wave. There's actually a P wave buried in that T wave. There's a little bump here as well. So because I have P waves in those T waves, clearly what's happening is the SA node is just firing on its own. And then the QRSs are kind of doing their own thing, because why would we have P waves buried in those T waves, right? So this is a tricky one. And at first glance, it appears to be a Mobitz 2, but we can see that those P waves are buried in the T waves. And so that's what makes this a complete heart block, or a third degree AV block. And National Registry loves second and third degree AV blocks because they are very easy to cause confusion. So that's why I wanted to spend a little time dissecting some of these. And then finally, let's look at yet another example of a third degree AV block. And here is one where the QRS complexes are actually narrow, they're not wide, and they're not quite as slow. So let's take a look at this. So here's a P wave, and there's a QRS complex. Here's a P wave and QRS, and here's a P wave. And then here's a P wave in between the QRS and T wave. And then here's a P wave on top of the T wave, right? So it's very obvious that you've got P waves all over the place. And then you've got QRSs. And so the P's are doing their own thing, and the QRSs are doing their own thing, and they're not really related at all, right? And again, this is a complete heart block. In this case, the QRSs are narrower and the rate is a little faster. So there's probably some underlying junctional escape rhythm going on. But at the end of the day, it is still a complete heart block. And what causes complete heart blocks? Well, many of the same causes as the other heart blocks, but just like a second degree type 2, a third degree is considered a high grade AV block and tends to require definitive therapy. These tend to be symptomatic. And again, this tends to cause a symptomatic bradycardia. So that's how you would treat it. Just like other high-grade AV blocks, these may be resistant to atropine. And we may see them in patients that have a pacemaker where that pacemaker is failing, right? And so what's happening is the pacemaker is no longer working. And so the patient has reverted back to the whatever underlying rhythm they're in, either a high-grade second degree, second degree type 2 or a third degree AV block. All right. And I believe that is the end of it. So before we take our first break, are there any questions? Anybody have any questions? All right, I've got 9:33. So let's just meet back up at 9:45 and we will finish up the first lecture talking about pacemakers and pacemaker rhythms. I'll see you all at 9:45. All right, welcome back, everyone. All right, so before we continue on, are there any questions over the AV blocks? All right. Just as a reminder, the notes that I used and will be using today can be downloaded from the notes file in Canvas if you want to look at those, reference them, and follow along. All right. With that in mind, let's move on. So now what I want to do is I want to talk about pacemakers and some of the various pacemakers that are out there, what kinds of rhythms we run into, and more importantly, or most importantly, what are some of the problems associated with pacemakers? All right, so I'm just going to shift my video here and go back to the iPad. Let's share. There we go. All right, excellent. All right, so we talk about pacemakers. There are three major types of pacemakers. So the first type of pacemaker is what you all should be familiar with because you learned how to do this last week. And this is something referred to as transcutaneous pacing, or TCP, and that is pacing through the skin, transiting the skin, the integumentary system. So you put the pacer slash defibrillator slash cardioversion pads on the patient, and then you initiate pacing, setting the rate that you want, and starting at your low output, moving up to high output, and you look for two things. The first thing you look for is what we call electrical capture. And then you verify the presence of mechanical capture. You ensure that the rate you set on the pacemaker it matches the rate that you can palpate. And so that's fairly straightforward. And so what you should see is you should see a pacer spike. And then that spike should be followed by a QRS complex. And then that should correspond with the pulse when you palpate. All right, so that's transcutaneous pacing. The second pacing paradigm is a more invasive form. And like transcutaneous pacing, it is temporary. It is not a permanent solution, but it's just a little more definitive, a little more invasive. And it is often a little more comfortable because with external pacing or transcutaneous pacing, we're having to use, right, you have something called transthoracic impedance, right? The tissues of the thorax kind of get in the way. And so we have to use a fair amount of energy to get through the chest wall and the various tissues. And that can be very painful and can be very anxiety inducing. And so one of the things we talked about last week is when you have successful transcutaneous pacing and the patient's heart rate, cardiac output increases, and their mental status improves, they may develop anxiety and they may have a lot of pain associated with that. Whereas the more invasive you get, typically the less pain you're going to have because you're not having to throw energy through the chest wall. So the second major paradigm is something called transvenous pacing. Transvenous pacing. And essentially what transvenous pacing is that you place a wire, essentially, a wire or a probe through a large vein or through a central line, essentially, the subclavian vein or the external jugular vein, or maybe even the femoral vein, if you need to. And then you thread that wire up through that vein into the vena cava and then drop that into the heart. And so you have a probe, a wire sitting in the heart, typically the right atrium. And then that probe can fire a signal off and act like the SA node, right? And it is clearly more invasive, but because it is in the heart, you don't need as the amperage does not need to be as high as you would see with transcutaneous pacing. So that is transvenous pacing. And then the permanent solution is typically an implanted pacemaker. And there are many different types and many different versions. And sometimes these pacemakers can also be defibrillators or cardioverters. And these are sometimes referred to as AICDs, or automatic implanted cardioverter defibrillators. And when you get history on the patient, you try to figure this out, right? It is the device. What does the device do? Because not all cardioverters defibrillators are also pacemakers, and not all pacemakers are cardioverter defibrillators. So you've got to figure out, okay, what exactly is this device supposed to do? Does it do one thing or does it do multiple things? All right. And when somebody receives implanted technology, they tend to receive education, and they will receive a card with some information about the technology. And this is a good thing for you to look at, because you can actually determine what in the hell this thing is supposed to do. And since we're talking about pacemakers, pacemakers will have codes associated with them. So you'll have what's called a pacemaker code. And a code can consist of up to about 6 letters. We're not going to cover all 6, but the first 3 are the most important for our purposes. They tell us the most information, the critical information that we need to know. So this is how it works. All right. So the first letter in a pacemaker code is telling you what gets paced. So where is that impulse going? Right. Typically with a pacemaker, what you have is you have a little battery pack and a little computer, and that is sometimes referred to as the pulse generator. And then you have an electrode that comes out of that goes into the heart. And this tends to be implanted under the skin in the chest. And then you have the pacer probe that goes out from that into the heart. All right. So the first letter is telling you what area of the heart is actually getting paced. And the common codes are O, which means none. So this device isn't pacing. Maybe it's an AICD, just a pure cardioverter defibrillator, doesn't do any pacing at all. The second letter, A, means that the atria is being paced. So that is to say that this is taking over as the SA node, right? So the patient has had a failed SA node, and so this pacemaker is taking over the role of the SA node, and so it is pacing in the atria. V is what we call the ventricle. So this is pacing in the ventricle, and then there's something called D, or dual, where it is pacing both the atria and the ventricle. All right. And dual pacing is sometimes referred to as AV sequential. AV sequential pacing, where the pacemaker will fire in the atria and then it'll fire in the ventricle as well. All right, so that's the first letter. The second letter is, where is the pacemaker sensing? So the pacemaker is sensing the patient's underlying heart rhythm, right? So where is that occurring? Where is the sensing, right? Is it detecting the patient's heart rhythm? If it's not sensing anywhere, we would just say, oh, and so there is no sensing. All right. A would be, it is sensing atrial activity. V would be, it is sensing ventricular activity. And then D, it is sensing activity in both the atria and the ventricles. And then the third letter is, what does the pacemaker do when it senses activity in the heart? Like, oh, the heart, there's activity, or there's some sinus rhythm. I sense a sinus rhythm, or I sense the heart is depolarizing normally, or maybe even abnormally. What am I going to do? So this is what we call the response to sensing. All right. So O is nothing. Whoa. We just experienced a crash. Sorry about that. We just had ourselves a little crash there. Okay, so O is nothing. The pacemaker doesn't do anything, or the device doesn't do anything. Okay. And then I is inhibit. So what that means is, if the pacemaker detects cardiac activity, the pacemaker will inhibit itself. It'll be like, hey, don't fire. I'm sensing activity here. All right. Everybody okay with that? Any questions there?
How is it inhibiting in the pacemaker? Is it providing a shot?
Yeah, it's telling itself, don't fire. You don't need to fire right now. I am sensing I'm sensing electrical activity. So it's inhibiting. It's inhibiting itself.
Is there a difference between the O or the I? They're both kind of doing nothing, but the I is sensing something and doing nothing?
Right. So O is, the pacemaker just doesn't do anything. It doesn't care. Right. It doesn't care that there is or is not electrical activity of the heart. For example, if you initiate transcutaneous pacing, right, like we did last week, does the monitor care what's going on in the heart?
Okay, I got it.
It's just, the monitor is just going to keep firing at whatever you set the rate and whatever the milliamps, and it's just going to keep doing that. Like the patient could go into VTAC or fib, and the monitor just keep on pacing, be like, I don't care. That would be like, oh, it just doesn't care, it doesn't do anything. Whereas I is like, hey, look at all this activity, stop pacing while there's this activity going on, and it stops itself. Whereas you would not see that with your transcutaneous pacemaker. Does that kind of make sense?
Yeah, absolutely.
Okay, cool. And then the other thing that it could do is what we call a T, and that is trigger. And so in response to electrical activity, it will trigger. It'll be like, hey, this is normal. Start pacing and let's make this activity go away. All right. So its response is to trigger, is to initiate whatever pacemaking programming is going on. And then there is D, dual. It can both inhibit and trigger. So you can see that not all pacemakers are the same, and pacemakers can do a lot of different things. For example, let's say that somebody has a pacemaker code of VOO. So that would mean that their ventricle is being paced, but that pacemaker does not sense anything going on in their heart, and it does not respond to sensing because it can't sense, right? That'd be VOO. That would be basically like a transvenous pacemaker. You put a transvenous pacemaker in, the probes in the heart. Well, a transvenous pacemaker would actually be AOO. It would be in the atria. And then you turn on the pulse generator and set rate and output, and that's that. But if somebody had a pacemaker in their ventricle and it was just firing away, doing its own thing, and it could not detect the heart's activity, then that would be VOO. But pacemakers that are have more complex programming, you might have something like DDD, where they have both the atria and ventricle being paced. Sensing is occurring in both the atria and the ventricle, and the pacemaker can both inhibit and trigger itself depending on the activity that it senses. So you can see that these pacemakers can be very basic in their programming or very complex in their programming. And I got a question here. Would the information card have additional information besides just the letters? Yeah, so often they're gonna say like what the company of the device is, what like the lot number, dates and things like that. That just allows you like, hey, maybe there's some battery issue and the battery came from this lot. And so yeah, it will have additional information. But the code is what we really want to look at, because that tells us, okay, what is this pacemaker supposed to do? And then when we look at the patient, we go, okay, what's actually going on? And is this a problem with the pacemaker, or is this some other problem with the patient unrelated to the pacemaker? Yeah. All right. So is everybody okay with that there? Does that kind of make sense? Again, we're just going for the basic concepts. You can really get into the weeds and take a deep dive on pacemakers, but I want you all just to have the basic understanding of them. All right. So now let's just take a look at what all of these, or what some of these paced rhythms look like. And some of them can look an awful lot like what you saw yesterday or last week when we did transcutaneous pacing. So here are some examples of different pacemaker rhythms. And all pacemaker rhythms are going to have a spike. And so you can see, oh, let me do a different color here, do that blue. So you can see the spike here. And so you can tell that this is actually atrial pacing because you've got a spike that is creating a P wave followed by a QRS. So this would be atrial pacing, right? So if you were to see this and you're looking at that patient's info card, right, you would know that at a minimum, atrial pacing is going on. All right. Now, on the other hand, this second example is ventricular pacing. So you've got a pacer spike followed by a QRS complex. And whenever something is occurring in the ventricles, the QRS complexes tend to be wide, right? That is a classic finding in the ventricles. So you see a pacer spike and a wide QRS. This is kind of what you all saw last week when you did transcutaneous pacing, because essentially transcutaneous pacing is an external form of ventricular pacing. So you've got a pacer spike followed by a QRS complex. And then here, this is yet another example. And this is what we call AV sequential pacing. And this is where you have pacing occurring in both the atria. So here is a pacer spike. And you can see it's associated with the P wave. And then here's a second pacer spike. And you can see that it is associated with a QRS. And so the pacemaker is depolarizing the atria, and then it's depolarizing the ventricles. So it's essentially taking on the role of the electrical act of the conduction system. So here's your pacer spike again, P wave, second pacer spike, QRS, right? So this is A, V sequential, A first, V second, right? So those are some examples of pacing that you will see in patients. So let's move on. And let me just show you some other examples. So here's yet another example of atrial pacing. So you've got the pacer spike here, and then you've got your QRS, you got a little P wave there. All right. And then this is an example of ventricular pacing. So this is just ventricular pacing without the atrial pacing. So you've got a pacer spike here, followed by a QRS. Pacer spike QRS, pacer spike QRS, pacer spike QRS, and so on and so forth. Very similar to what you saw with transcutaneous pacing. All right. So with that in mind, let's now move on and let's talk about some of the problems that we can run into with pacemakers, what we call malfunctions. So the first of the problems I want to talk about is something called failure to capture. So failure to capture means that the pacemaker is sensing, right? It is sensing, okay, and it is trying, right? It is sensing and it is firing, but it is not causing electrical capture. So what you will get is you will get pacer spikes without QRS complexes. So you see you have a pacer spike there and no QRS complex. And then you do have a pacer spike and a QRS, pacer spike QRS, pacer spike QRS. So this looks to be ventricular pacing. And then you have a spike here, no QRS, a spike here, no QRS. So you've got these dropped QRSs. So these spikes are not producing QRSs, and so you have a failure to capture. And this may be due to many things. Maybe there is a problem with the pulse generator. It is not generating enough amperage. Perhaps it's a battery problem. Maybe there is a problem with the electrode or the probe that is going into the heart or onto the heart. maybe it is frayed, or there's a something going, some problem with conduction through it. But either way, this is what we call a failure to capture situation. All right. Another situation is called failure to sense. So in a failure to sense situation, the pacemaker is not able to sense the patient's underlying electrical activity. And so what you have here is, you can see that there is an underlying rhythm here, right? So this here is a PQRST complex. It's coming from the sinus node. And here's another PQRST complex. So the patient has underlying cardiac activity, but you can see these pacer spikes. There's a pacer spike here. There's a pacer spike here. Why do I have, what's going on here? There's a pacer spike here. And then you see a pacer spike here. And where did that pacer spike happen to land? Did you guys see that there? It happened to land on the, so here's the P wave. Here's the QRS complex. Here is the T wave. That pacer spike just happened to land on the T wave and cause an R on T phenomena and cause that patient to deteriorate into ventricular fibrillation. So this pacemaker actually caused an R on T phenomena. So clearly, this pacemaker is not sensing the patient's underlying cardiac activity. Otherwise, it would be able to sense and inhibit, right? It should be inhibiting itself. It should be like, hey, don't fire. Particularly don't fire on the T wave. And so this is what we call failure to sense. And the life-threatening complication of a failure to sense is it happens to fire on the T wave and cause R on T phenomena. Another problem that you can run into is something called failure to output. And a failure to output is not the same thing as a failure to capture. A failure to output is simply the pacemaker fails to generate an impulse. So you don't see spikes. So here we kind of catch it failing in the failure in the act. So you have a spike here, and then a QRS here, a spike here, and a QRS, a spike, no QRS. But then what happened? What we got here? You got this long pause, and maybe it looks like there are possibly some P waves going on here. So maybe this is the underlying rhythm is some third degree AV block. And then you have this escape rhythm that picks up here. So clearly there should be additional spikes going on here, right? To generate additional QRSs, and it's not generating them for whatever reason. Maybe it is not sensing, or is the response to sensing is off. But either way, it is not generating an impulse when it should be generating an impulse. And then the last thing that I want to talk about is something called a runaway pacemaker. And a runaway pacemaker is essentially where the pacemaker begins firing rapidly. So you've got pacer spikes, and they're firing very rapidly, and they're causing an abnormal rapid increase in the patient's rate, right? This is called a runaway pacemaker, right? It is causing an abnormal tachycardia to occur. It is run away. And obviously there's danger with that. Now, the problem with this is there isn't much we can do about some of these, like a runaway pacemaker. There's not much we can do about that other than recognize, oh, the pacemaker's run away, the patient's rate is too rapid. There's not much I can do other than I need to get this patient to definitive care where they can interrogate the pacemaker, reprogram it, and stabilize the situation. Just like let's see here. Just like, where did it go? There we go. Just like failure to sense. There's not much I can do about that, right? There's not much I can do for that pacemaker other than recognize, oh man, this pacemaker is discharging in inappropriate times. I need to rapidly transport that patient to definitive care. Now, there are some pacemakers that can be turned off. Not all, but some can be turned off. And does anyone know how we can switch some of these pacemakers off and kind of put them into a dormant mode, if you will?
With a
Isn't
magnet?
it a magnet?
Yeah, so some pacemakers will respond to a magnet. And there are special magnets. They actually look like donuts, circular. It's a thick circular magnet, kind of a hole in the middle, looks like a donut. And what you can do is you can place that on top of the pulse generator that's implanted in the patient's chest. And that'll just kind of put the, typically it'll put the pacemaker on pause, particularly if you've got like a runaway pacemaker, or failure to sense. Then you can put that on, and that will kind of put that pacemaker into a kind of a dormant situation. It's not always going to work. It's not very consistent because all pacemakers are different company, different manufacturers, different things, but that may be something you can do. And if you carry magnets, you may contact medical control. You'll have the pacemaker card with the codes and be like, hey, do you want to try this? This is what's going on. We've got a runaway pacemaker, or we have a failure to sense that's causing RNT phenomena. That's really it. Other than that, you need to take them to definitive care, where there's a little machine that you can put on top of that pacemaker. You can interrogate it, figure out what's going on, change the programming, but sometimes even that won't work if you've got like a fractured lead, or you've got some mechanical issue with the battery or pulse generator. And then the last thing that I want to mention, real quickly is, and this is very old school, and this is going to be very rare, but I do want to mention this, and that is the source of energy for these pacemakers. So most contemporary pacemakers use a more traditional battery pack. But let me ask you all a question. What were some of the original pacemakers? What was their energy source? Let me ask you all that question.
Was it like the movement of the patient?
No.
Was it NiCad, the older batteries?
So yeah, there's nickel cadmium, and then lithium ion, which essentially do the same thing. They essentially have metals that allow the electrons to flow from one area to another area. But no, this is something else. This is actually the same technology that certain deep space satellites and probes use. Like if you want to send something to, say, Jupiter, where there isn't enough light, the light is very low, and so there isn't enough light for solar cells, and so there are alternative ways of creating electricity. This is actually 1950s technology.
Radiation?
What do you mean by radiation? You might be, you're moving the right direction.
I guess like a material that maybe just inherently has energy to it.
Yeah, you're moving in the right direction. Yeah, so this is actually something called a radioisotope thermoelectric generator, often denoted as an RTG, a radioisotope thermoelectric generator. And essentially what they do is they use an effect known as the Seebeck effect. And without getting too technical, essentially what happens is you have a radioactive substance, typically something like plutonium, all right? And then that like plutonium-238, and that plutonium decays, right? It decays. Those plutonium atoms are unstable and they decay and they release alpha particles, which are helium nuclei. So it decays, and as it decays, it releases these helium nuclei. And in addition to that, lots of heat gets released. So you have the helium nuclei or the alpha particles being released, and then you have lots of heat. And then what they do is they have what are called thermocouples built into it. And you've got these thermocouples, and those thermocouples are able to convert that heat into electricity. Hence the term radioisotope, that's a plutonium, thermoelectric generator. And so the issue here is these people have little lumps of plutonium in their body, and that can potentially be problematic, if you might imagine. However, with that in mind, it would be incredibly unlikely that you would run into this, because this is a technology that is no longer being used in contemporary pacemakers. But every so often, you know, somebody, you know, may have one of these older devices. Again, it's probably going to be very rare, very unlikely, particularly in the United States. But it is a possibility that maybe somebody dies and they have this in, or they're involved in some major trauma where perhaps that RTG is compromised, and then that sets you up for a potential radiological incident. So I don't want you to run around worrying about this, but just think about it, because it is, you know, a very rare possibility that you could run into a situation involving one of these older RTG based devices. Okay, so that brings us to the near the conclusion of the second part of lecture for this morning. So before I let you all go on break, and we will meet back up at 1300 after this, where we will talk about ventricular dysrhythmias and cardiac arrest rhythms. I want to make sure that I answer any questions you all may have. So are there any questions? Okay, make sure I'm caught up in chat here. Okay, looks good.
Just a quick question.
Listen,
So in the ventricular paced rhythm, is your P wave your paced spike?
yeah, so with a ventricular paced rhythm, you may not even have a P wave, right? Just like last week when we did pacing, right? Transcutaneous pacing. That's transcutaneous pacing is essentially an external form of ventricular pacing. So you're just going to see a spike and then a QRS complex. And you're not, with ventricular pacing, you're not doing anything with the atria. So that is actually firing inside of the ventricles and causing the ventricles to depolarize. So you may not have any atrial activity at all. Did that explain it, or?
Yes, sir, it did. Thank you.
Cool. Yeah, not a problem. Yeah. And I wish it was simple. You know, it would be nice if everybody had AV sequential pacemakers, but it's just, you know, everybody has, you know, some of the older pacemakers, that's all they do is just ventricular paced, and they, you know, they can't really sense much. They can't really respond to sensing. And that's where that code, particularly the first 3 letters, really comes in handy, right? And you know that if somebody, you know, has a code of like, let's say the code is VVD, for example, right? So that's ventricular paced, ventricular sensed, and it can both trigger and inhibit itself. You know that that has fairly complex programming, where something like VOO is going to be a pacemaker that has a very simple code and can't really do a whole lot and can't really respond a whole lot to the patient. And that also might mean that the patient's heart, what their heart can do, is pretty limited as well, that their cardiac conduction system isn't really capable of doing anything intrinsically. And so they don't need a whole lot of, they don't need a pacemaker that is very nuanced. So again, that's why we kind of covered the codes and why it's important to look at that and kind of figure out what's going on. Okay, let's see here. Any other questions before we take a lunch break? All right. Excellent. Well, that's I think that's all I've got for this morning. I will see you all back at 1300, where we'll talk about ventricular dysrhythmias and cardiac arrest. And remember, there will be the 2 homework assignments due by the morning, and quiz number 2, which will be due by midnight tonight. And we will go over those answers tomorrow morning. But I will see you all back at 1300. And if you have any additional questions, just let us know at that time. And we will see you all soon. All right.
Thanks, Chris.
Thank you all. Take care.